So as I mentioned, we're now moving into our third session in the Paths to Engagement. It was observed earlier how important it is, of course, for the National Forum to bring its knowledge, the knowledge of its members, and our reach to bear on policy. And this is a session where we'll be significantly focused on that and describing an effort, a strategic effort of the National Forum. It's entitled Engaging Stakeholders Across Health Sectors on Value and Access, and our moderator is our Executive Director, John Clymer.
Thank you, Dave. Thank you very much. So I'm going to try to tell you just a quick introduction and as little of the story as possible, because the people who have created the story are those who accompany me here on the dais at the moment. So just working across the stage very briefly, we've already met Dr. Mike Cropp, CEO of Independent Health. Norm Linksy is Executive Director of Mended Hearts. I mentioned we brought together payers, patients, sitting next to Norm, providers. Brendan Mullen, Executive Vice President of the American College of Cardiology, ACC, and then the chair of this merry band of change agents is Jennifer Robinson from the University of Iowa. So as I mentioned in the Executive Director report, we had a number of National Forum members approach us and say, our members, whether they were providers or patients or public health practitioners, are really concerned about the difficulty that some people are having getting access to innovative therapies that they need, and we're also concerned about not breaking the bank and killing the engine that drives the economy and provides for healthcare. And we really want to get involved in this discussion. We want to get out of the bleachers and onto the playing field, but we're not suited up to get on the field yet, and we don't know the game plan, so we'd really like for the National Forum to help us prepare to get onto the playing field. So we responded to that with some research. This is not just about transparency. This is also about gratitude and about partnerships. We approached our friends at Amgen. Hilly Page. If you don't know Hilly Page, Hilly, stand up. If you don't know Hilly Page, you should, by the way. He's a true gentleman and a great partner. So we approached Amgen and said, our members are asking us to help them get involved in this. Is this something that Amgen might financially help make possible? And Amgen, Hilly and his colleagues said, yes, we could do that. So they provided the funding and then stepped away. Right? So it was up to the members and the participants to set the agenda. As I said, we brought together the 5 Ps, groups representing patients, providers, payers, public health, and pharma and biotech, all around the same table. And after doing a study that was based on a number of structured interviews with different organizations here in the room and even some others, to get different perspectives, to understand how do patients view value? How do patients view access? What does it mean to them? How do providers view those questions, those issues? How does public health view them, and so forth? We compiled that into a report. It's available on the National Forum website. We've gotten a lot of compliments on it. I hear from people, hey, I use that report a lot in my work. So I commend it to your attention if you're not familiar with it. And then we convened this group around a table. And in that initial convening, we established some conversation and a basis of open discussion and understanding. And I think I'm going to pause at this point, and maybe we can just start with Jennifer as chair of this group and talk a little bit about what's been accomplished, just a sort of a quick level set, and then we'll work our way down the panel and ask each of these esteemed colleagues to comment on what happened, what took place from your perspective, what it means to your organization. And, you know, Brendan Mullen, just for one example, anytime I'm trying to reach Brendan, he either is in a meeting about value and access, on his way to one, or just returning from one, right? So there's tons of action being convened or run by other organizations related to value and access. So I want to know from each of you why, you know, you don't need the 41st one of these, right, just to fill up your calendar. It's already full. So what is it? What's the difference here that has drawn you in and has you leaning in today? So, Dr. Robinson?
Right. So John invited me to be the chair of this effort, and my stomach kind of sunk, and I thought, oh my God. And it's been really fantastic because we have all gotten together, listened, and are moving forward, I think, on what will be a very productive activity. So we were convened December 2016, just down the street at the AHA, around a square table, and really made an effort with 20. It was about 20 people, and everybody was forced to talk, and we wanted to hear what everybody had to say, and it was truly informative to hear everybody's perspective on this issue of getting access to therapies. So as part of that exercise and learning and kind of brainstorming at that meeting, we were able to come up with kind of a mission statement, which is to enhance health and well-being by supporting people's access to evidence-based care that is appropriate for them. And so then we continued to meet and have regular calls, and have since now also identified more specifically bullet points, and then I'll share with you at the end what the actual action items are. But to identify, we thought there were two important things we needed to do. One is to identify evidence-based strategies for determining the appropriateness of care, and I want to point out evidence-based because we're blessed in the cardiovascular field with the vast amount of evidence, and how do we translate that into making people not just prevent disease but to be well. And it also needs to be appropriate, and appropriate varies by the stakeholder. And then the second bullet point was to support implementation of evidence-based care that aligns incentives for patients, providers, payers, and other stakeholders. Because we ultimately all need to be incentivized to do the right thing. So we have had monthly meetings, and I think some kind of unique aspects of this sort of operationalizing is one, to be sure everybody is heard, but also we've had calls where we actually run the role, and each member is invited to share briefly their activities so that we can synergize off of one another's efforts, which I think has been quite nice. We have also been solicited by ICER to comment on their evidence updates for these PCSK9 inhibitors. This is this expensive new class of cholesterol drug, which in the scheme of things maybe isn't that expensive when it now costs $1.4 million to treat cancer, but perspective, but for the cardiovascular space, quite expensive. So we have been commenting on those, and I think had some modest influence on how that report was developed. We've had webinars to educate the panel members on specifically value frameworks, value-based insurance design. And then the last part, and I think John had mentioned, we have a website, a Value and Access Clearinghouse, which has the report. And we're also, planning to build it out as we develop materials, white papers, reports, connecting the members. But I think just to have a sidelight, I think this is a key aspect of what the National Forum can do, is to provide a clearinghouse to all of our members, because every time I talk or come to these meetings, I talk to people and you're all doing things, the same things. It would be nice to share best practices so we can kind of take the next step learning from previous activities. But we hope we're developing out, I think, a very nice, robust website so that we can expand it to incorporate that. So at our last meeting in September, we developed an action item. These are the things we are working on. One is to understand the best practices for payer-purchaser coverage decisions, and so working with Mike and his group to really learn. There are insurers that are paying for these PCSK9 inhibitors for appropriate patients. So how can we learn from that, perhaps set up standards for best practices? What's the decision process these groups go through, so we can, again, provide a framework for others to deliver best practices to their covered lives. The second one is that there are a lot of things we talked about. We only chose 4. The second one is patient engagement strategies. So how can we engage in shared decision-making in the healthcare setting between having clinicians have the appropriate information, and how do we engage patients in that decision-making process to adhere to evidence-based therapies and engage in that decision-making. The third thing was to develop a framework for identifying low and high-value care that meets the needs of stakeholders. And this is important because, as I understand it, people are only kind of willing to spend so much money on healthcare, right? I think we may have kind of overstepped that a little bit. So how can we identify low-value services, get rid of those, and free up some money for things that are truly high value that improve the health and well-being of patients? And so, Brandon, I think hopefully you'll comment some more on that. And then the final one is patient adherence. And Fred and the FDA last year put out an adherence report, and how do we build on that to try to increase adherence to therapy. I already have one. This is not related, I just thought it'd be time to tell you. So we're going to do social marketing on statins. So how can we sell statins to the U.S. public in an evidence-based fashion? How do we get the right message out there and have our patients ask their doctor, well, why am I not on a statin? And I realize that's a lofty goal. But again, I think all of these things have spin-offs that are of interest to various groups. So that being said, I think we will just turn it over to Brendan, and maybe you can comment about how we got you. I mean, we have all these people at our meetings, and it's like, wow, they came, that's great. So.
Great. Well, thanks. It's good to be with everyone this afternoon. John, thanks for the invitation. And Jennifer, I've followed Jennifer's work for a long time, so it's always great to be able to be in any room with her and experience the way she thinks about this work. I have to admit, John, that this morning over breakfast, we're trying to get our 6-year-old and 8-year-old, and my wife, who's the chief of government affairs and public affairs for ASTO, which I think there are some members of ASTO here or staff. She said, "What's your day look like today, Brendan?" And I told her, and she kind of looked up from her cereal, and she's like, "Really? They're going to let you off the reservation?" So she kind of made me a little nervous because she spends much of her life in Washington talking with important folks and trying to make these points. I think she's a little nervous when they let me to free range here. But why are we here, and why is the ACC here? I think there are a couple reasons. One is an observation of what's happening in the clinical environment, particularly for secondary prevention of heart disease, particularly atherosclerotic disease. And that is, I have never seen in the last 10 years a more inspiring, optimistic, and dynamic time in terms of the therapies that are available to prevent patients from having a second event. There are probably at least 6 new major classes of medications that are all capable of materially reducing residual risk in patients by double-digit numbers in large randomized controlled trials. Okay? And that doesn't include what we're doing in AFib and heart failure and a whole bunch of other areas. Yet at the same time, I've never seen a market so ossified, so rigid in terms of the adoption of these new therapies, of actually getting them into patients. And so you have to wonder, what's this relationship? We have such a dynamic, great scientific opportunity, great therapeutic opportunity, and no one seems to be benefiting from them. And so going by class of drugs, as we're working on this and having watched this get steadily worse over the last 8 to 10 years, you have to start stepping back and thinking about this a little bit systemically. And I think there are sort of 2 zero-sum games that we're operating in that are part of the root causes. There are multiple root causes in this scenario, but part of the root causes. The first one is I think we're genuinely finally out of money, right? So anytime someone says, yeah, this is cost effective, it reminds me of if someone came to me and said, look, Brendan, I can make you a billionaire if you just invest $10 million with me right now. And my response is, I don't have $10 million to give you, right? So the idea that these new therapies are cost effective, that's great, except we're already out of money. And so anytime we spend more money on this, cardiovascular medicine, anything in medicine, we're not spending it on roads, we're not spending on education, we're not spending on climate change, we're not spending on defense, we're not spending on infrastructure. Anything that you care about in this country of ours, we're not spending it on because we're already spending almost 20% of it in healthcare. So there's no more money. The second thing I think this is a zero-sum game is that the political discourse has essentially gotten to being a zero-sum game. And when I say political discourse, I'm not talking about big P politics, Republicans and Democrats. What I'm talking about political discourse is how human beings in society resolve conflicts in a way that generally benefits most of us, aka compromise and negotiation. And I think as a result of what's happening in white buildings to the left and to the right of us, and exacerbated by social media, we've gotten to the point where we see everything as zero-sum. So when we advocate for our issues, I can only win, because if I'm not winning, then someone else is winning and I'm losing, right? And so both of those dynamics are extremely corrosive to our ability to solve problems at value and access. So when John and Jennifer said, can you come? Definitely said yes because of the first problem. And then it was this sort of realization that if we keep attending meetings like this and we all just kind of say our thing, even though we're all essentially on the same team, we're not going to make any progress. And the progress that needs to be made is some of us need to be willing to come forward, actually all of us eventually, and say, you know what, here's the thing I'm going to stop doing. Here's the thing that you need that I don't need as much, that I can give up in order to make room. And I think by solving that second problem, that second zero-sum game, that we don't all think of it as winners and losers, but we can actually win together by actually some shared sacrifice, by giving something up, by recognizing that we're not doing the right thing all the time, acknowledging that, getting rid of it, waste. That makes space in the first problem. That makes resources available to allocate them to the medications, to the patients, to the therapeutic options that are going to be really important.
Follow up on that, you've actually done one pass at identifying low-value cardiovascular care.
Yeah, and
as part of these initiatives.
And I think one of the things that as the college, we have a pretty good track record. I feel comfortable saying this because as the American College of Cardiology, starting 20 years ago, we pioneered guidelines. Starting about 10 years ago, we pioneered appropriate use criteria. We were early adopters of the Choose Widely program. So we have expensive, sophisticated technologies that are not appropriate for every patient. And I think we were one of the first organizations with a great member leadership that said, you know what, we can actually go out there and say some of the things that we can do, and we may even get paid well for doing, we shouldn't be doing for every patient. It might actually be hurting the patients, nonetheless costing society a lot of money. But what we haven't been doing, what I'm interested in exploring, is can we bring some of those things to bear in the context of specific negotiations and say, hey, if we can carve out X percentage of unnecessary stenting, for example, would that free up resources to get, say, patients who are clearly should have PCSK9s with familial hypercholesterolemia or on their third or fourth or fifth event, of uncontrolled LDLs. Could we actually agree that those folks should be getting some of those resources and actually make space for forward progress overall?
Norm, you came to the table as a participant in lots of other conversations happening different places about these similar issues. So what is it that has kept you at the table or is keeping you at the table, and what are the patients who Mended Hearts represents getting from this?
John, I think you're asking exactly the right question, as you did right at the very beginning of your introduction to this panel discussion. And one word I heard, one theme I've heard in common, both with Brendan and with Dr. Robinson, is the constant use of the word everyone at this table. One of the things about the National Forum, and a number of us have been involved in this in various lives over the years, over the many years, is that there's a real common theme to what the forum has done over the years. It's right there on that sign I've been looking at all day in 3 words, and I wrote them down. We ignite collaboration. We ignite collaboration. And the fact that uniquely, and I know, John, as you said, we have so many things to do every single day, so many events that we can go to. We're not looking forward to filling our calendars or anything, but just looking at all the panels that have been had today and the people at this room, many of us, and I'm wearing the Mended Hearts label right now. I'm representing 20,000 patients, 20,000 members, 200,000 patient visits per year, 300 chapters, all of which seem to call me on Friday afternoons. We have to do something about that. But uniquely, everybody in this room, we're working together, and if not, we will be working together really soon towards this common ends. I haven't seen it anywhere else where you have patient groups, nonprofit physician groups, payer groups, government, industry partners, and others all in the same room trying to figure things out. And as you said, John, in your introductory remarks, the issues are very, very serious, both in terms of demonstrating value and in terms of access. And I'll come back to that in just a moment. And a lot of our constituents, a lot of the people that we work for and that we represent are really angry, really upset, really, really confused. But we only have one chance to get this right. And the fact that, again, kudos to Dr. Robinson and the other members of the Value and Access team have been putting out some outstanding work, have been focusing on real answers, real resolvable answers, has been, to me, gives me hope in the face of what's some not so good news out there all too often. In terms of the Mended Hearts membership, just as one group representing the patient voice, again, we have a lot of very active members all around the country. We've been around since 1951 and collaborate very, very well with hospitals, with physicians all around the country. In terms of value and access, what I hear right now from lots of our members, most of our members, is the concern about access, just access to the drug, device, or treatment that they need that they need at an affordable price that their physician or other caregiver says they need. That's what I hear constantly through the field, and what keeps us at this table, enthusiastically so, at the Value and Access table, is the fact that we are working together in very productive ways to help increase that access. In Mended Hearts, as with other patient-related groups, we have what we call our Patient Advocacy Network, PAN, where we have well-trained volunteers, identified, properly trained, that we trained in a number of sessions, both here in DC and remotely, and they're back in the States now, and they're working in very productive ways. And what's really good, just looking around the table, a lot of those people in our patient advocacy network, they're working with you good folks. A lot of you good folks. I'm seeing heads nodding here, working with nonprofit patient groups, working with physician professional groups, working proudly with our industry partners, because 99.9% of the time, the circles in that Venn diagram for all of us just intersect perfectly. It's the only way that we can do that, by igniting that collaboration. One last point I'll put in terms of value, we're very eager as an organization to work more with the people in this room to demonstrate the value of peer-to-peer support and how things like that can actually reduce readmissions, increase compliance, and other things that we're so driven to pursue.
Thank you, Norman. You've been in this field, in this sphere for, what, 3 decades?
Four
decades.
And I'm only 39 years old.
That's a miracle. And you go to meetings all the time, convenings on different issues. I think you commented in the meeting last month about how often you participate in a meeting that has all of the 5 Ps at the same table. How often is that?
Very, 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 very rarely. Today,
All right.
in this group.
Thank you.
And Norma, I just want to make one more comment, which I thought was particularly valuable from the patient perspective, because part of it's patients have a right to access, but I think you made a really critical point. Patients also have a responsibility to participate in their care and adhere to therapies, and I think both of those things will be brought forward as we work on this. Great, thank you.
So Mike, there are all these echo chambers that have been set up in different places where you get, this is not to call anybody out, but you get patients and providers together, and it's really easy for them to get on the same page on this and have a lot of fun beating up on payers. Right? So there's a whole lot of noise and advocacy, which is useful, but not always the coming together that leads to constructive disruption in the marketplace, to disrupt the stasis. So I know you're a risk taker. I know independent health is very progressive as a payer and has a rich tradition of that. But as a payer and as someone who's a leader, not just a CEO, but a leader within the field, what brought you to this conversation, to this table, and what are you getting from it?
Sure. Well, thankful to be here. So thank you, John, for the opportunity. And it's exciting to be in this room with the various stakeholders. For us, if I think about the population health triangle as it relates to cardiovascular disease, at the very base of the triangle, we've got people who don't even know what they don't know. And so the vastly undiagnosed population is probably the biggest swath that we have. And then we've got people who know that they have risk factors and are not being treated to the goal. And you go right up the triangle, and at the very top, you've got the highest risk people who might benefit from the PCSK9s. So for us, figuring out how do we really fill that triangle up from the bottom all the way up to the top is really key. And we know that we can't do it alone. We know that we can't do it in our traditional partnerships just with the providers at home and listening to our members. We need other touch points. And all the voices that are here and part of the forum, I think, represent those touch points in terms of how can we know more about who we haven't diagnosed? How can we get at that? Talking with Kat earlier about some collaborations that we could do to really fill out that base of the triangle. And then how can we reach the diverse aspects of our community in new and different ways so we can get those people who are diagnosed into treatment and to goal. And then working with professional societies like the College of Cardiology to really identify those non-value-added services that are just sucking the money out of the system and preventing us from filling that triangle as robustly as we should. So all the parties are here to help us really execute on that triangle all the way from the base all the way up to the apex.
Great, great. So the first time that this group convened, as Jennifer said, in December of 2016, one of the things that impressed me most was how many times during that meeting different people around the table said, "Wow, I have never heard someone from your sector speak so openly. Wow, I've never heard anyone talk about the problem from your perspective in that way." So there was new communication and a foundation of trust, I think, was established for engagement. And then, as Jennifer said, the group rapidly reached a consensus goal statement. And show of hands, how many people in the room know Seth Baum? Darn near everybody, right? So Seth Baum's the president of the American Society of Preventive Cardiology, and Seth was, the consensus goal statement was achieved over the phone on a conference call. And so we finished that meeting. Ben was an important participant in that, and hang up the phone, Seconds later, here's Seth on the phone. He says, "Man, I cannot believe we just did that. I never thought we would get all these different sectors to agree on something like that." Now, that's just a goal statement. What happened at the last meeting was far more important because it was setting the action agenda. But as we built this momentum, first with the goal statement, then with consensus strategies, then we had people like Mike leaning in saying, "I want to bring more payers into the fold. I want to help bring more payers, more of my peers to the table." And we've had additional patient organizations and others get more actively involved, and we've been very fortunate to attract additional support. So Santa Fe came into the fold and said, "We want to help support it," so we're very grateful for that as well. So there's momentum building here, and what excites me about it is it's not the National Forum itself building this momentum. That would be too heavy a lift. It's the people around the table. It's you all who are doing it, and you're not just building momentum, you're creating an updraft. So, yeah.
John, you're exactly right. And I think Mike used a really important phrase a couple of minutes ago, constructive disruption. And I like that. I mean, let's face it, in a lot of ways, the relationship between people like us and the payer community has been adversarial. Let's face it, I worked years ago, way before this young man was born. I actually had his job back at ACC, fairly close to it. And there were some tough discussions there. And with a couple of other professional societies, I worked with wonderful societies along the way. I mean, stepping into the belly of the beast, so to speak, with the payers, those were generally not really great conversations. At the same time, laying all the cards on the table, having everybody at the table, and as you said, getting more people at the table that are from all segments of the community. It's the only way we're going to get this done.
And I think one we haven't mentioned, we do have employers at the representation at the table too. Right. So there's I think good representation of that viewpoint.
You know, one of the things I think these forums they actually require hard work, right? Imagine that.
Yeah.
And one of which is peeling an onion, understanding what the root causes of these problems are, right? So, to build on Norm's point, Mike's point, I think there's a tendency, right, in the provider community to paint the insurers with a broad brush, unfairly, most likely. I think sometimes we get painted back in that same direction, right? It's easy to do it, particularly on Twitter. I've noticed I don't see a lot of people apologizing, compromising, or in general discussing sophisticated scientific ideas on Twitter, right? Yeah, that's sort of the discourse du jour. And you get in a room and you realize, oh, this is someone else who is actually trying to do the best they can for their organization or for society. So in terms of peeling the onion, one of the things that's fascinating about these discussions, I think the National Forum's helping us to do that, is realize that actually there is basically complete consensus around, particularly in the PCSK9, which patient should be receiving this medication. And we won't get into the technical details of it, but I don't care if you're going to the National Lipid Association or the ACC or most of our insurer colleagues or the patient advocates, at least at this core, concentric circle, we all agree about the same patients, right? And then as we get farther out, we can debate the relative merits and costs. It's perfectly fair. And yet they're not getting access to it. Okay. So what's going on there? And one of the things that we've discovered that I think has helped the ACC to tack some of our strategies is that by working with colleagues who are clearly trying to do the right thing in the insurance industry, we realize that payers are responding to this differently, and there are some payers that it really makes sense to collaborate with and to build these relationships, and whom it feels like we could compromise and negotiate a better outcome. And then there are some that we think we might want to pay a little bit closer attention to that are pursuing policies that maybe aren't constructive. And by the way, that's the exact same thing for cardiologists, right? It doesn't take a lot of Google searching around cardiologists to know that there are bad actors amongst physicians and cardiologists. But I tell you what, the vast majority of them are trying to do the right thing for their patients in their constrained resources and busy lives. And if we can use that as our consensus point, I think we can identify both the bad actors and operate against them as they should be, and then have a lot more common ground to sort of negotiate opportunity for moving forward.
So, Mike, where do you see the next first down in this effort? I mean, we do want to reach the end zone, but we've got to work our way down the field. So, and it's fall. So, where?
Well, I
and
think
you're from Buffalo.
Yeah, that's true. Everything's going to shut down in probably a couple hours. I think that having the conversations about the triangle and sort of understanding where do we sit with respect to each layer is really an important starting point. And then we can define multiple, I think, goal lines in this effort. Because, I couldn't tell you right now how many of our people have been screened and how many haven't been screened. I would really like to know that. I can tell you at the apex of the triangle, how many folks are getting the PCSK9s and how many are not. I think that there's an opportunity for us to help work with Jennifer and the college to be able to help sort of reverse engineer our process. Because right now, about 65% of all of our requests are being approved. And I think that's pretty good. I'm sure that we can improve that. But I do think that it's important that we maintain a focus on all the levels of the triangle as we go forward, because I'm just concerned about that base. And when we talked earlier about the 200,000 preventable deaths, more of them are coming out of that base than at the apex. So,
Great. Well, we have about 5 minutes available, and so we can open the floor. Michael Hargret, I see your hand up. And can we get a microphone to Michael? Well, but we're recording this for posterity, Dr.
Here's one.
Dr. Howard's great. Yeah.
So Michael Hargret from the ACC as well. One thing that, this has been a very good conversation, and I know that it's been going on a while. And just to sort of leverage your point about the pyramid in the bottom of the pyramid and those at the bottom of the pyramid, just want to make sure that within this discussion of value and access, that the issue of health disparities isn't lost in this discussion, right? Oftentimes when we're thinking more of condition specific and what do you do about hypertension, heart failure, what are the rates and who has the highest prevalence, then we're going to go into the health disparities and the underserved communities. But I think those same communities should be centered and should be a central part of the discussion when we're talking about value and access. So although it might not be shown here on the stage, but I would like to know, so what types of strategies or what type of discussions, or how does that come into the discussion that you've had thus far?
Well, you talk about, we have 16 other members that aren't on the stage with us. And I think I absolutely agree, and I think it's been kind of fundamental to this process that we're addressing getting people on evidence-based therapies across the spectrum of health, disease, communities, race, ethnicity. That's key. And actually, even for our sponsors, you can't get a PCSK9 inhibitor unless you're on evidence-based therapy and the best dose of statin. So it actually does come together. And I think a lot of these screening activities are also something that we'll need to bring on. But we have public health. We have other members. John, you can address that.
Right. Yeah. We have ASTO is at the table. NACHO or NACDD is at the table. I could go on and on with the list. But I think to the point that Jennifer just made, Michael, one of the key success factors here has been the coalescence of the group around the principal evidence-based approaches to improving health. Everybody found common ground around that. And in my experience in this town, it's one way to transcend, Brendan referred to the small p political divide, one way to transcend capital as well as lowercase political divides is by sticking to the evidence base. And we have that on our side. You know, the thing is, we know what works. We know how to prevent most of those 200,000 heart attacks and strokes that Mike just referred to. We know how to do it, so it's a matter of joining together to do it. Stan?
So, here we go. I remember back in 2005, I read an article that was published by the British Medical Journal back then about the poly pill. Okay, some of you are familiar with it. And it basically said this. It said that if all people over the age of 55 were to take this pill, barring complications that they can on an individual basis, that it would reduce heart disease and stroke by 80%. And I remember that really sticking in my head, and I said, my God, what can I do in the public health arena that would come even close to that? So that, first of all, that's a provocative question, and it's still out there, by the way. The poly pill is being used, I know, overseas. Here's the other thing I want to bring up, and it's the idea of a taboo that existed for a long time. Perhaps it still does, but it's part and parcel to what we're talking about here, and that's namely public-private partnerships. So, for instance, if I had told you, my goodness, 10 years ago,
Stan,
that,
by the way, I think everybody in the room knows you, but just in case, would you tell us where you are
Stan
from?
Shanley from I head up the cardiovascular health unit at the Minnesota Department of Health. Anyway, so 10 years ago, if I had told you that the Minnesota Department of Health was forging a public-private partnership with Medtronic Foundation, okay, people would have been knocking on my door and pounding, saying, what the hell are you doing? Okay, well, fast forward to just a couple of years ago, we actually did that. We created a public-private partnership with Medtronic Foundation because they're involved in an international initiative called Health Rise that focuses on diabetes and hypertension control. And one of the countries happens to be the United States, and in the United States, it happens to be in Minnesota that they're initiating this initiative. Consequently, we're able to work with them. Imagine that, a Department of Health working with a for-profit entity. So when we talk about engagement and leveraging, I would highly recommend that in order for us to move this bar, that we really start looking at more and more public-private partnerships.
Thank you. And that's certainly what this is. So, Dr. Senatore, we're over time. 15 seconds from the FDA.
I wanted to address Michael's question about health disparity. I was working with Keith Ferdinand, and we published an article that addressed this very bluntly and directly. And even though you have medication adherence as a key parameter, you have to address the disparity. And one thing that seems to work is some of the efforts associated with this meeting, which is patient engagement. Things like the barbershop or community relationships that do enhance medication adherence and somehow does something to equilibrate the ethnic disparity, but there's a lot of work that has to be done there. And
thank you. Thank you, Dr. Senatore. So I want to thank Jennifer, Brendan, Norm, and Mike for a great panel. Will you please join me in applauding? And we're going to make way for the photo bomber.